welcome to the Deep Dive. Today we're inviting you to think about one of your body's, well, unsung heroes, an organ you interact with literally every second of every day, yet often take completely for granted. It's your ultimate protective barrier, a sensory marvel, and, a silent workhorse, accounting for a surprising 15% of your total body weight. Yes, we are diving deep into your skin. Our mission today is to literally peel back the layers of human skin and its fascinating underlying subcutaneous tissue. We've taken the stack of material you've provided, articles, research, our own notes, and our goal is to extract the most important nuggets, helping you become instantly more informed about this intricate and vital organ. We'll explore its incredible anatomy, its diverse functions, the myriad of conditions and injuries that can affect it, and the fascinating ways medical science is working to heal and protect it. Get ready for some truly surprising facts and those aha moments we all love as we give you a shortcut to genuinely understanding what makes our skin so remarkable. And why its health demands the attention of so many crucial surgical and medical disciplines, from plastic surgery and dermatology to general surgery and surgical oncology. Okay, but let's unpack this. 15% of total body weight, that's a lot. And it's continuous with our mucous membranes. It's truly massive. But beyond its sheer size, what makes the skin such a complex and critical organ, fundamentally?
Well, what's truly fascinating here is how many different tissue and cell types come together, working in perfect concert, really, to create this incredible protective shield. It's far more than just a passive covering that keeps things in. Your skin is an incredibly active, dynamic organ, constantly defending you from external threats, everything from bacteria and viruses to harsh chemicals and damaging UV radiation.
Right.
But paradoxically, precisely because it's your outermost layer and so integral to so many bodily functions, it's also highly susceptible to its own set of problems. We're talking about chronic inflammatory disorders, mechanical and thermal injuries, and of course a wide spectrum of both benign and aggressive tumors. When you understand its foundational role as your body's primary defense, you really start to appreciate just how debilitating skin conditions can truly be.
That makes perfect sense. So if we start to dive into its structure, the material tells us there are 3 distinct main layers. How do these different layers work together? And how can they vary from person to person?
Exactly. Your skin is quite unique because it's derived from both ectodermal and mesodermal germ cell layers during early development, which gives it this really diverse set of capabilities. These 3 main layers, the epidermis, the dermis, and the hypodermis, also known as the subcutaneous tissue, they aren't uniform across your entire body. They differ significantly in their specific composition and thickness depending on factors like the particular location on your body, your age, your sex, and even your ethnicity. But despite these variations, they function harmoniously, participating in numerous essential life activities that extend far beyond simply being a barrier.
Okay, let's start at the very top then, the outermost layer, the epidermis. The sources describe it as primarily a protective, highly keratinized layer of cells. What's truly happening within this thin, dynamic outer shell?
Right, this layer is just a marvel of constant regeneration. You could almost imagine a microscopic, continuous construction site. Primarily, it consists of continually regenerating cells called keratinocytes, which make up about 90% of its cellular mass. The epidermis is highly stratified, meaning it forms several distinct sublayers, typically 4 or 5 layers, depending on whether it's thick skin, like on your palms and soles, or thinner skin elsewhere. From deep to superficial, you have the stratum basal, that's your base layer where new cells are born. Then there's the stratum spinosum, stratum granulosum, followed by the stratum lucidum, only in thick skin, remember, and finally the outermost stratum corneum. These layers essentially represent keratinocytes at differing stages of their approximately 30-day life cycle. They're constantly moving upwards and changing their form as they mature, eventually shedding off.
So the real aha here is that your skin is literally rebuilding itself every month, shedding old cells and making new ones even while you sleep. That's a continuous microscopic construction site. And I understand this outermost layer is also unique because it doesn't have its own blood supply. Is that right?
That's a crucial point, yeah. Absolutely critical for understanding how this organ heals and gets nutrition. The epidermis completely lacks its own vascular structures. It's avascular. It gets all of its necessary nutrients and oxygen from the dermal vasculature, which lies directly beneath it, purely by diffusion.
Wow.
Think of it like a plant getting water from the soil. The epidermis draws everything it needs from that rich blood supply just below.
That's a fascinating detail, and a vascular layer supporting itself through diffusion. So if keratinocytes are the main players, what other specialized cells are we finding in this outer shell, and what are their unique roles?
The keratinocytes really are the workhorses, you're right. The stratum basal, that base layer, is a deep single layer of continuously replicating cells. This is where the life cycle of keratinocytes begins. These cells are bound to their basement membrane by tiny, super strong anchors, almost like rivets, and to other keratinocytes by structures that act like, well, super strong Velcro fasteners, creating a very cohesive and resilient layer. This germinative layer also lines structures like hair follicles, and it's a vital regenerative source for the epidermis, especially after partial thickness wounds. You need that layer to regrow skin.
Okay, so beyond the keratinocytes.
Right, beyond them we have other crucial players. Langerhans cells, for instance. These are like tiny mobile immune sentinels within your skin. They're constantly patrolling, looking for any foreign invaders attempting to pass through. When they find something suspicious, they grab it and alert your body's wider immune defenses. They're basically your skin's first responders against threats. What's important to note is that these vigilant cells can be functionally impaired by UV radiation from the sun, which actually plays a role in why too much sun can increase your risk of skin malignancies. Interestingly, their effectiveness at antigen presentation means scientists are exploring their potential as vaccine delivery vehicles in the future.
Interesting.
Then there are melanocytes, also located in that deepest basal layer. These cells are responsible for producing the pigment melanin. And here's a key insight. Differences in skin pigmentation across people aren't usually due to differing numbers of melanocytes, but rather the activity of those individual melanocytes, how much melanin they produce, and how it's distributed.
So it's not the number, it's how busy they are.
Exactly. Melanin forms a protective sort of umbrella-like cap over the nucleus of keratinocytes, shielding the cell's genetic material from damage by radiation. This helps explain why lighter-skinned individuals with less active melanocytes producing less protective melanin are more prone to developing cutaneous malignancies.
Okay, that makes sense.
We also find Merkel cells here. These are specialized cells that act as slow-adapting mechanoreceptors, essential for your sense of light touch. They're clustered in sensitive areas like your fingertips, lips, and hair follicles, and they communicate directly with your brain, letting you know when something gently brushes your skin. Clinically, their significance arises because Merkel cell carcinoma, a rare but aggressive cancer, is linked to these cells.
Got it.
Finally, the epidermis hosts a few other specialized cells that contribute to its overall function. You have a small number of lymphocytes, which are immune cells that reside here, and then there are TikToker cells found in the nipple epidermis in some individuals, which some studies suggest could be a source of Paget's disease of the nipple, a rare form of adenocarcinoma.
That's truly incredible. Such diversity packed into such a thin layer. And it's not just cells, but these amazing extensions you mentioned, the epidermal appendages. What vital roles do they play in our everyday lives?
That's right. These appendages are extensions of the epidermis, though much of their structure resides deeper in the dermis. First, we have sweat glands, which are absolutely crucial for thermoregulation. The most numerous are the eccrine sweat glands, found in greatest numbers on your palms, soles, armpits, and forehead. They can produce, believe it or not, up to 10 liters of sweat per day.
Wow, 10 liters.
Yeah, it's the most effective way your body regulates temperature, using evaporative cooling, which kicks in when your body gets too warm. Then there are the apocrine sweat glands, found in specific areas like your armpits, groin, and around your nipples. These glands activate around puberty, influenced by sex hormones. Interestingly, their secretion is initially odorless, but when bacteria on your skin get to work on it, that's what creates what we know as body odor.
So it's the bacteria, not the sweat itself.
Primarily, yes. There's even a third type, epicacrine glands, similar to apocrine, but opening directly to the skin surface, also appearing at puberty. Both types have unique cells around them that act like tiny muscles, contracting to help squeeze out the sweat. Next, we have pilosebaceous units. This is a multi-component unit consisting of a hair follicle, a sebaceous gland, a tiny muscle that makes your hair stand on end, that's your erector pili muscle, giving you goosebumps, and a sensory nerve.
Right, the goosebump muscle?
Exactly. These units are found throughout your body, except on your palms, soles, and mucous membranes. The germinal epithelium lining these units is really important for regeneration, especially after partial thickness injuries or even after skin grafts. The sebaceous glands within these units secrete sebum, which is basically an oily lipid that lubricates your hair and skin. Their activity is heavily influenced by hormones, making them very active during puberty, and they're most numerous on your face and scalp, which, can contribute to acne. And finally, we have nails. These hard keratinaceous structures cover the tips of your fingers and toes. They consist of three main parts: the nail root, the visible nail plate, and the free edge. Nails do more than just grow. They protect your distal digits and enhance the counter-pressure function of your fingertips, which is surprisingly vital for fine motor skills and grasping objects.
Moving deeper now, the dermis sounds like the structural engineer of the skin. What gives it its incredible strength and elasticity, and how does it support everything above it?
If we connect this to the bigger picture, the dermis is truly the skin's primary support system. It's derived from the mesoderm, the middle layer of cells in embryonic development. It not only anchors the epidermis to the underlying subcutaneous tissue, but also provides protection and, crucially, houses all those neurovascular structures and epidermal appendages we just discussed. Its thickness varies significantly across the body, from being incredibly thin around your eyelids to a robust 4 millimeters on your back. It's generally composed of two distinct layers, the papillary layer and the reticular layer. The papillary layer is the more superficial one, characterized by tiny finger-like projections that interlock with the base of the epidermis. Think of it like Velcro. This intricate interlocking structure significantly increases the surface area between the dermis and epidermis, which is vital for two reasons. It makes the skin much more resistant to tearing or shear forces,
Right.
and it greatly facilitates the diffusion of nutrients up to that avascular epidermis we talked about. This layer also has a denser population of various cells. Deeper down, the reticular layer is almost entirely made up of a coarse, interwoven network of strong fibers and the gel-like ground substance that surrounds them.
So it's literally a mesh of fibers. What kind of fibers are we talking about, and how do they contribute to the skin's properties and perhaps even its aging?
Absolutely. The fiber structure is key to its strength and flexibility. Collagen makes up almost all of the dermis's dry weight, predominantly type I collagen, which is incredibly strong, and a bit of type 3, which is more delicate. These collagen bundles are arranged more loosely in the superficial papillary layer, but deeper in the reticular layer, they're organized into strong interwoven bundles, giving the skin its incredible tensile strength. And here's where it gets really interesting and a direct aha moment for anyone concerned about skin aging.
Okay.
In healthy skin, these dermal fibers are constantly being broken down and rebuilt. However, UV radiation from the sun dramatically increases the activity of enzymes called matrix metalloproteases, or MMPs,
MMP, so.
which actively degrade collagen. This leads to increased breakdown and disorganization of your skin's support structure, directly contributing to the visible signs of aging, like wrinkling and weakening in sun-exposed areas.
Wow, so the sun is literally speeding up the breakdown.
Precisely. It's a powerful reminder that our environment is constantly sculpting our biology. In addition to collagen, we have elastic fibers, which give your skin its incredible stretch and recoil its ability to snap back into place. These fibers, also produced by fibroblasts, can stretch to twice their original length and return to their normal configuration. Just like collagen, their health and turnover can be negatively impacted by UV radiation,
Right.
further contributing to loss of elasticity and skin laxity over time, causing skin to sag. And all of this fibrous network is embedded within a hydrated, amorphous ground substance. This substance is made of remarkable molecules that act like super sponges, holding vast amounts of water up to 1,000 times their weight.
Incredible.
This ground substance is absolutely vital for maintaining the structural integrity of the dermis, allowing cells to move around, and effectively acting as a natural shock absorber, redistributing forces placed on the skin. It's what keeps your skin plump and resilient.
It's truly a complex ecosystem down there.
Yeah.
What are the main cell types of the dermis, and what unique roles do they play?
Within this intricate network of fibers and ground substance, we find several key cell populations. Fibroblasts are the fundamental cells of the dermis. They are the primary architects and builders, responsible for producing all the dermal fibers, the collagen and elastic fibers, and that ground substance we just talked about. They're often referred to as the workhorses of wound healing because they can also transform into myofibroblasts, which are cells containing contractile filaments that help to literally pull the edges of a wound together, reducing its size.
Ah, so they help close wounds too.
Exactly. Dermal dendrocytes are another important group. These are a type of immune cell that resides in the dermis. They are involved in detecting foreign invaders and processing antigens to present them to the wider immune system, much like the Langerhans cells in the epidermis. They also play a role in orchestrating wound healing and tissue remodeling. Then we have mast cells. These are key players in your immune system responsible for immediate allergic reactions, like type 1 hypersensitivity. When triggered by an allergen, they rapidly release histamine and various other signaling molecules, leading to the redness, swelling, and itchiness commonly seen in allergic responses like hives.
So the dermis is structural, but also a hub for immune activity. And it's also where the skin gets its vital blood supply and sensation right. It seems to be the most active layer in many ways.
Precisely. Unlike the avascular epidermis, the dermis is richly supplied with blood and nutrients, which is absolutely essential for its health and for nourishing the epidermis above it. This is facilitated by two main networks of blood vessels: a superficial plexus just below the epidermis and a deep dermal plexus at the bottom of the dermis. These two networks are connected by a sophisticated system of arteriovenous shunts. These shunts are crucial for thermoregulation. They can either open up to divert more blood flow to the skin, releasing heat, or close down to conserve heat, keeping you warm. They can also divert blood flow to vital organs during emergencies. Associated with these blood vessels are the beginnings of lymphatic vessels, which act like a drainage system, collecting excess fluid and proteins from the tissues and returning them to your circulatory system.
And the nerves.
And yes, the skin is also a highly specialized tool for interacting with our environment, carrying a rich network of nervous tissue to facilitate this. We have an afferent component, which consists of free nerve endings and specialized sensory receptors like those for pressure and vibration. These are responsible for conveying all sorts of information about your environment to your brain, things like touch, pressure, temperature, and pain. Then there's the efferent component, which carries signals from your brain, controlling numerous functions within your skin, such as those blood flow adjustments for temperature regulation, making your hair stand on end for goosebumps, and controlling sweat secretion.
And finally, the deepest layer, the hypodermis, also known as subcutaneous tissue. What's its primary function and how does it connect to the layers above, serving as that crucial bridge to our deeper anatomy?
Right, this deepest layer is essentially a richly vascularized, loose connective tissue that physically separates and attaches the dermis to your underlying muscle and fascia. It's made up primarily of pockets of lipid-laden adipocytes, fat cells, which are separated by fibrous septa. These septa contain cellular components similar to the dermis, along with the deep ends of sweat glands and neurovascular structures that continue to supply the cutaneous tissue. The hypodermis serves multiple crucial functions. It provides insulation to help regulate your body temperature, stores energy in the form of fat, and protects the body from mechanical forces, effectively cushioning you. It also allows your skin to glide smoothly over deeper tissues without tearing or excessive friction. Think of it as a natural shock absorber and insulation layer.
So we've covered the incredible design and intricate biology of the skin. But what happens when this amazing protective shield encounters trouble? Let's turn our attention to when skin goes awry, starting with inflammatory conditions, where the body's own immune systems can sometimes overreact. Our sources highlight several, and first up is hidradenitis suppurativa. This sounds like a painful and often debilitating condition affecting specific areas of the body.
It really can be. This condition, also known as acne inversa, typically affects areas of the body that have a high concentration of apocrine glands and experience skin-on-skin friction. So think armpits, the groin, the perineum, and under the breasts. It's characterized by tender, deep nodules that can expand, coalesce, and spontaneously drain pus or fluid. Over time, these often form persistent tunnel-like sinus tracts under the skin that lead to significant scarring. And while bacterial infection can definitely complicate flares, it's primarily an inflammatory disorder, not just a simple infection. It's more common in females, about 3 to 1, and typically emerges during their 20s or 30s. There's also a strong association with smoking and obesity, and about 1/3 of affected patients report a family history, suggesting a genetic predisposition.
And the cause?
The underlying problem, well, it's not fully understood, but it seems to involve inflammation of the hair follicles and surrounding structures, which then triggers a wider immune response. Treatment is guided by a staging system, the Hurley classification. For early stages, topical and systemic antibiotics can be used, alongside good hygiene. For more advanced disease, where you see those deep tunnels and significant scarring, it often requires more aggressive interventions, like radical surgical removal of the affected skin, laser treatment to destroy inflamed follicles, or even biologic agents that target specific inflammatory pathways in the immune system.
Wow, quite a range.
Yeah, and a key challenge is that even with complete surgical removal, recurrence rates are still high, sometimes up to 50% in certain regions. Because of this, surgeons often prefer wound closure methods other than simply stitching it up directly, such as using skin grafts or local tissue flaps to cover the area.
That sounds incredibly complex and challenging for patients. Another condition mentioned is pyoderma gangrenosum, which sounds particularly challenging given its progression and association with other systemic diseases.
Indeed, pyoderma gangrenosum is an uncommon but very severe inflammatory condition of the skin. It starts with what looks like sterile pustules, but these then rapidly progress into painful ulcerating lesions that have very characteristic purple undermined borders, almost like they're tunneling under the skin around the edges. It's often diagnosed in individuals between 40 and 60 years old, with a slightly higher prevalence in females. What's fascinating here, and a crucial insight, is that while its exact cause is unknown, it commonly arises in individuals who have underlying hematologic malignancies, like certain blood cancers or chronic inflammatory disorders, such as inflammatory bowel disease, like Crohn's disease, or rheumatoid arthritis.
So it's often linked to something else going on.
Very often, yes. The most commonly affected sites are the legs, but these painful lesions can occur anywhere on the body, and sometimes even affect internal organs. The diagnosis is primarily clinical, meaning based on the appearance and progression of the lesion, but only after carefully ruling out any infectious causes. Treatment involves managing that underlying systemic disorder first and foremost. For example, optimizing treatment for a patient's Crohn's disease. Then, systemic anti-inflammatory medications like corticosteroids or powerful immunosuppressants are often used. For cases associated with Crohn's, a class of drugs called TNF-alpha inhibitors have shown marked improvement. It's vital to note that attempting surgical therapy for these ulcers without proper systemic treatment generally leads to a high rate of recurrent disease. It really emphasizes the need for a comprehensive multidisciplinary approach.
Now, epidermal necrolysis, the name alone sounds severe. Our sources mention Stevens-Johnson syndrome and toxic epidermal necrolysis as part of this spectrum, highlighting widespread skin destruction.
This is truly a rare but life-threatening severe mucocutaneous disorder characterized by extensive destruction of the skin at the dermo-epidermal junction, that interface between the epidermis and dermis. Stevens-Johnson syndrome, or SJS, refers to cases where less than 10% of the total body surface area is involved, while toxic epidermal necrolysis, or TEN, is for cases with greater than 30% involvement with an overlap syndrome in between.
Okay.
They are now considered the same clinical entity, differing only in the extent of skin affected. Think of it like a severe, widespread skin peeling that often looks very much like a severe burn.
That sounds terrifying.
It is. Clinically, it usually occurs within 8 weeks of starting a new drug treatment. It typically begins as a macular rash on the face and trunk, which then spreads rapidly to the extremities within hours or days. A positive Nikolsky sign is often present, where even gentle lateral pressure on the skin causes the epidermis to simply separate from the dermis. The rashes then blister and coalesce, forming large, fragile, fluid-filled sacs that eventually burst, leaving extensive, raw, partial thickness wounds with exposed dermis, much like what you see in a severe burn victim. Mucous membrane involvement is seen in 90% of cases, affecting the mouth, eyes, and genitals, and sometimes even the respiratory and gastrointestinal tracts. These widespread skin and mucous membrane manifestations are often associated with high fever and excruciating pain.
And it's usually drug-related.
Etiologically, yes, it's rarely well documented as an adverse reaction to various drugs. While over 100 drugs have been implicated, high-risk ones include certain anticonvulsants, sulfonamide antibiotics, allopurinol used for gout, and specific NSAIDs. Pathophysiologically, it involves the body's own immune cells, specifically cytotoxic T cells, which mistakenly attack and kill keratinocytes, leading to widespread skin death. There's also a genetic component. For instance, genetic testing is recommended for certain ancestries before prescribing specific drugs due to strong associations with certain HLA gene types.
So how is it managed? What's the prognosis?
The prognosis of this condition is directly related to how much body surface area is affected and the development of secondary complications, particularly infections and the loss of hemodynamic stability due to massive fluid loss, similar to severe burns. Modern burn unit and intensive care unit management has significantly decreased mortality rates. The first and most critical principle of management is the immediate discontinuation of the offending drug.
Stop the drug.
Absolutely. This can dramatically increase chances of survival, especially for drugs with short half-lives. Other management principles include maintaining the patient's fluid balance, ensuring early nutrition, and implementing aggressive measures to reduce the risk of infection. like meticulous wound care and the use of topical antimicrobial dressings. The use of systemic corticosteroids and IVIG in the acute setting remains controversial, with mixed results in studies. Unfortunately, there's still no single treatment with clearly demonstrated universal benefit for epidermal necrolysis.
From the body's own reactions, let's shift to external assaults.
Yeah.
Injuries when our shield is physically breached. Radiation injuries sound like a particularly modern challenge, given our increasing exposure, both environmental and medical. How does radiation impact the skin at different levels?
Right. Radiation injuries can stem from environmental UV exposure, primarily UVA and UVB rays from the sun, or from medical treatments like radiation therapy for cancer. The skin's response differs based on the type and depth of penetration. For instance, UVA, which constitutes about 95% of the UV rays reaching Earth, penetrates deeper into the dermis, affecting those collagen and elastic fibers we talked about.
Okay.
In contrast, UVB rays are mostly absorbed in the epidermis, primarily affecting the keratinocytes and melanocytes.
So short-term effects versus long-term.
Exactly. In the short term, solar radiation causes erythema, or redness, and pigmentation. The pigmentation from UVA is due to immediate darkening of existing melanin. UVB, however, triggers your body to produce new melanin as a protective mechanism for the basal keratinocyte nuclei, which you see as a tan developing a few days later. Now, the fascinating long-term effects of UV exposure lead to chronic skin changes, such as irregular pigmentation, dark spots, and importantly, a significant impact on collagen and elastic fibers. Long-term UV exposure actually increases the activity of certain enzymes that impair the natural turnover of these crucial dermal fibers.
Like those MMPs again?
Precisely. This results in a disorganized accumulation of damaged elastin and an altered ratio of collagen types, directly leading to loss of firmness and resilience in the skin, which we perceive as wrinkles and an aged appearance. It's a direct molecular link between excessive sun exposure and visibly aging skin.
And therapeutic radiation for cancer treatment.
Therapeutic radiation, used extensively in oncology, works by damaging the DNA of target cancer cells to destroy their ability to replicate. However, it inevitably causes collateral damage to surrounding healthy tissues. The most radiosensitive components of the skin are the basal keratinocytes, the cells that constantly replenish your epidermis, along with hair follicle stem cells and melanocytes. Acute changes manifest within weeks as redness, swelling, and hair loss. Long-term effects, presenting weeks to years after exposure, include permanent hyperpigmentation, skin tightening, thickening, and fibrosis. The skin's functional integrity can be compromised due to damage to blood vessels and tissue death, leading to poor wound healing and even chronic ulcers that are very difficult to treat. Severe cases may warrant surgical excision of the damaged tissue and complex reconstruction, sometimes requiring transferring healthy tissue from another part of the body.
Mechanical injuries, from simple cuts to complex bite wounds, are incredibly common. How do surgeons approach these, especially when the skin's integrity is compromised? And what are the specific concerns with something like a bite wound?
Well, treatment of mechanical wounds varies significantly based on their depth. The exposure of underlying vital structures like nerves, vessels, or tendons, and the presence of contaminating debris or infection. For clean, simple lacerations, the approach is often to thoroughly irrigate the wound, remove any devitalized or contaminated tissue, and then close it primarily with stitches, ideally within a few hours of injury.
Okay.
However, for grossly contaminated or obviously infected wounds, it's often best to allow them to heal by secondary intention, meaning they close on their own over time, or to perform delayed primary closure, where the wound is left open for a few days to allow drainage and then closed later. Interestingly, negative pressure wound therapy, often known as VHC therapy, can significantly boost granulation tissue formation in such cases by removing excess fluid, promoting circulation, and reducing bacterial colonization.
In bite wounds, they seem particularly risky.
They are a major concern. Dog bites alone account for, 4.5 million bites to humans in the U.S. in a single year? And they can quickly lead to severe deep tissue infections if not properly recognized and treated. The hand is a particularly vulnerable area due to its complex anatomy, which allows for rapid progression of deep infection along relatively avascular structures like tendons, potentially leading to long-term disability.
Nice.
Early bite wound infections are typically polymicrobial, meaning they involve multiple types of bacteria. Common bacterial culprits include Pastorella multicida from animal bites and Eikenella corrodens from human bites, among others. A crucial piece of advice here: Prophylactic antibiotics are strongly recommended for human bites, as studies have shown they significantly reduce infection rates. There's still some debate surrounding the primary closure of bite wounds, especially for non-facial wounds, with some studies suggesting similar infection rates to secondary healing if properly irrigated and debrided, but caution is usually advised.
Chemical burns sound particularly insidious, given their potential for deep tissue damage, sometimes in unexpected ways. What makes them so dangerous, and how are they managed?
You're right. Chemical burns, while making up a smaller percentage of all burns, unfortunately account for a disproportionately high number of burn-related deaths, sometimes up to 30%. The extent of injury depends critically on the specific chemical agent, its concentration, the volume of exposure, and the duration of contact. A key distinction here is between acid and basic solution injuries.
Acid versus base, okay.
Acid injuries typically result in coagulative necrosis. This basically means the tissue proteins clump and form a solid, superficial eschar or scab-like barrier. This protective barrier actually limits further tissue penetration. Acids can also cause additional thermal injury due to exothermic reactions, meaning they generate heat. In stark contrast, basic solutions, or alkaline agents, cause liquefactive necrosis. This means there's no protective barrier formed. Instead, the tissue dissolves, allowing the chemical to penetrate much deeper into the underlying tissues, causing far more extensive and severe damage than may initially be apparent on the surface. Common examples of alkaline agents you might encounter are drain decloggers and industrial cleaners containing sodium hydroxide or lye.
So how do you treat these?
For treatment, the first and foremost principle is immediate and copious dilution of the offending agent. This means flushing the affected area with large amounts of water or saline for an extended period, up to 30 minutes for acids, and often 2 hours or more for alkaline injuries.
Flush, flush, flush.
Exactly. It's explicitly discouraged to attempt to neutralize the offending agent with an opposing chemical, as this can create an exothermic reaction, generating more heat and actually increasing tissue damage. Subsequent management is then based on the burn depth and location, similar to thermal burns. There are specific antidotes for certain chemicals, like calcium gluconate for hydrofluoric acid burns, but the general principle remains massive dilution.
And hospital-acquired chemical injuries.
Yes, a common hospital-acquired caustic injury is extravasation injury. This occurs when irritating or damaging medications, particularly certain chemotherapies, leak out of a vein and into the surrounding soft tissues. These can cause significant pain and tissue damage in vulnerable patients, presenting with swelling, pain, and blistering. Management often involves conservative measures like elevating the limb and sometimes saline aspiration to dilute and remove the agent, though specific chemical antidotes lack strong, consistent trial support.
From chemical to thermal extremes of temperature can also wreak havoc on the skin, as we all know from burns and frostbite. How do these thermal injuries cause damage, and what are the core principles of their management?
Thermal injuries are complex, with the extent of damage depending on both the temperature of the exposure and its duration. Burn management often revolves around the concept of 3 distinct zones of injury. First, you have the zone of coagulation, which is the innermost area where irreversible tissue death has already occurred. Second, well outside this, is the zone of hyperemia, which shows signs of inflammation, but the tissue is viable and will likely recover. And then there's the crucial zone of stasis, which lies in between these two.
The zone of stasis.
Yes, this area has questionable tissue viability, and it is in this zone where proper and aggressive burn care things, like maintaining good blood flow and preventing infection, can actually salvage viable tissue and decrease the overall extent of the injury, making it a critical focus for intervention.
Okay, and frostbite, that's different, right?
It involves different mechanisms of damage, yes. Hypothermic injuries, like frostbite, cause direct cellular damage due to the crystallization of both intracellular and extracellular fluid, which literally freezes and ruptures the cells. During rewarming, further damage can occur due to shifts in fluid as the ice melts. Indirect effects include microvascular thrombosis, where tiny blood clots form in the small vessels, leading to tissue ischemia, meaning a lack of blood flow, and subsequent swelling and inflammation, which propagate the injury even further.
So rewarming itself can cause issues.
It can, but despite this ongoing damage during rewarming, the standard treatment for frostbite injury begins with rapid rewarming in a warm water bath to 40 degrees C to 42 degrees C. This is then followed by meticulous wound care, limb elevation, and supportive medications like topical antimicrobials and systemic anti-inflammatory agents to minimize further damage.
Pressure ulcers are a major concern in patient care, often seen as a marker of quality. What's the science behind these injuries, and how can they be prevented and managed?
Pressure ulcers, commonly known as bed sores, are a significant problem, particularly in critically ill patients and those who are chronically bed or wheelchair bound. They develop when prolonged pressure on an area restricts blood flow, leading to tissue ischemia, a lack of oxygen, and eventual tissue death. Bony prominences like your hip bones or heels are particularly susceptible to these injuries because the pressure isn't easily redistributed across a larger surface area. To give you an idea of the forces involved, pressures greater than twice the capillary perfusion pressure, which is about 30 millimilli-HG, can cause irreversible tissue damage in as little as 2 hours in animal models.
Just 2 hours.
Yes. The most common locations for pressure ulcers include the ischial tuberosity, your sit bones, greater trochanter, hip, sacrum lower back, and the heel, reflecting the typical pressure points in sitting or lying positions. Pressure ulcers are typically grouped into 4 stages, from stage 1, which is just non-blanching redness over intact skin, to stage 4, which involves full-thickness tissue injury with exposure of bone, muscle, or tendon.
So prevention is key, I imagine.
Absolutely. Management first and foremost involves prevention. This includes strategies like using pressure offloading hospital beds or specialized cushions, regular patient repositioning every 2 hours, early patient mobilization when possible, and prophylactic silicone dressings. From a wound healing perspective, patients should be nutritionally optimized, and surgical debridement of dead tissue is performed as appropriate. While deep pressure ulcers might seem like an obvious surgical indication, the decision to operate isn't always straightforward. When surgery is needed, the goals include draining any fluid collections, widely removing necrotic and scarred tissue, and reconstructing the area with well-vascularized tissue, often using muscle or fasciocutaneous flaps, to ensure tension-free closure and a healthy blood supply. Negative pressure wound therapy, or NPWT, plays a crucial role in wound management by removing excess fluid, promoting blood circulation, decreasing bacterial colonization, and significantly increasing vascularity and the formation of healthy granulation tissue, thereby reducing wound size and preparing it for definitive closure.
It's incredible that we can now engineer skin substitutes. What are these products, and how do they help in wound management, especially for complex injuries?
Yeah, it's a really exciting area. Bioengineered skin substitutes are increasingly common and critical tools in managing soft tissue defects, particularly large or complex wounds that might not heal on their own or need better support. They are designed to either provide a regenerative matrix that the body can grow into, or to directly stimulate the body's own dermal regeneration while simultaneously protecting the underlying soft tissue and structures. They generally fall into 4 types: autografts, which are tissues taken from the patient themselves; allografts, which come from human donors; xenografts, derived from other animal species; and synthetic or semi-synthetic biomaterials, which are constructed in the lab and may or may not be combined with biologic materials.
And you mentioned a cellular dermal matrices.
Right, a significant type among these are cellular dermal matrices, or ADMs. These are derived from either human donors or animal sources, and they are essentially a scaffold made of essential components like collagen, elastin, and other structural proteins, but crucially, all the original cells have been removed.
So it's just the framework.
Exactly, just the framework. They serve as an incredibly effective bridge for complex wounds, especially those with exposed nerves, vessels, tendons, bones, or cartilage, where you need to build up a healthy base before applying skin. The body's own cells migrate into this scaffold, and it helps guide the regeneration of new tissue. They can be temporary, requiring removal before definitive grafting, or permanent, integrating directly into the host tissue and allowing for direct skin grafting on top. This is a truly exciting area, pushing the boundaries of what's possible in wound repair.
That's truly fascinating, thinking about skin as something we can engineer. Now, the skin is an incredible barrier, but it's also a common site for bacterial infections when that barrier is compromised. How are these classified and treated, particularly with the rise of resistant bacteria like MRSA?
You're right. The FDA actually categorizes skin and skin structure infections into uncomplicated and complicated to help guide treatment. Staphylococcus aureus, often called staph, is by far the most common culprit, isolated in a staggering 44% of specimens from skin infections. This includes the infamous methicillin-resistant Staphylococcus aureus, or MRSA. However, other bacteria, including gram-negative species like Pseudomonas aeruginosa or E. coli, also play a significant role, particularly in immunocompromised patients, such as those with diabetes or weakened immune systems.
So what falls into the uncomplicated category, and what are the typical approaches for these more common, less severe infections?
Uncomplicated infections generally involve relatively small surface areas, typically less than a few inches, and the bacterial invasion is limited to the skin and its superficial appendages. Examples include impetigo, which is a superficial infection typically of the face, resulting in characteristic honey-colored crusting; erysipelas, which is a bright red, well-demarcated infection localized to the upper layers of the dermis; cellulitis, a deeper spreading infection affecting the deeper dermis and subcutaneous tissue, which looks red and swollen; folliculitis, an inflammation of the hair follicle; and furuncles, which are collections of pus within a hair follicle, which can then coalesce into larger, deeper abscesses called carbuncles.
Right, boils and carbuncles.
Exactly. For minor infections like impetigo or simple folliculitis, topical antimicrobial creams can be very effective, even providing coverage for MRSA. Folliculitis often resolves with good hygiene and warm soaks. For simple abscesses like furuncles and carbuncles, simply draining the pus incision and drainage is often sufficient without the need for systemic antibiotics, unless there are signs of a widespread inflammatory response, like a fever.
Okay.
For non-purulent cellulitis, meaning without pus, systemic antibiotics targeting common skin bacteria like streptococcus are typically recommended initially. If there's no improvement within a couple of days or if symptoms worsen, then coverage for MRSA should be added. For purulent cellulitis, including skin abscesses, empiric MRSA coverage is usually the priority. Antibiotic choices ultimately depend on the suspected bacteria and local resistance patterns.
And what about the complicated infections, the ones that go deeper or cover a large area, posing a much more serious threat?
These include extensive cellulitis, covering a large surface area, and crucially, necrotizing soft tissue infections, or NSTIs. These are severe, rapidly progressive, and life-threatening infections of the deeper soft tissues, including the fascia and muscle. NSTIs, which include conditions like necrotizing fasciitis, carry a very high mortality rate.
Oh boy.
Unfortunately, ranging from 25% to 40%, even with aggressive treatment. They are frequently associated with underlying conditions like diabetes, intravenous drug abuse, obesity, and any condition that weakens the immune system.
And STIs sound particularly aggressive. What makes them so dangerous, and how are they identified and managed, especially when initial findings might be nonspecific?
A high index of suspicion is absolutely critical for NSTIs because they can initially present with nonspecific findings, such as pain that seems completely disproportionate to the visible skin findings, or rapidly worsening cellulitis. While gas within the soft tissue seen on imaging, like X-rays or CT scans, is definitively diagnostic, we often cannot wait for imaging in suspected cases. The threshold for surgical exploration and debridement should be very low.
Go straight to surgery if suspected.
Exactly, especially in weakened or immunocompromised patients, because time is absolutely of the essence. NSTIs are classified into types based on the bacteria involved. Type 1, the most common, is polymicrobial, meaning it involves a mix of several types of bacteria. Type 2 is monomicrobial, often caused by a single aggressive bacterium like Streptococcus or Staphylococcus, with MRSA contributing to an increasing number of community-acquired cases. Type 3 is a rare but extremely severe subset resulting from a Vibrio vulnificus infection, typically acquired through traumatized skin exposed to salt water.
And the management principles.
The management of NSTIs is built upon three foundational principles. First and paramount is source control with wide and aggressive surgical debridement. This means removing all necrotic and devitalized tissue until healthy, bleeding tissue is encountered. This often requires multiple trips to the operating room.
Multiple surgeries.
Often, yes. Second is broad-spectrum intravenous antibiotics, initiated as soon as possible to cover a wide range of bacteria. And third is aggressive supportive care and resuscitation to manage the patient's severe systemic response to the infection. While hyperbaric oxygen, which involves breathing pure oxygen in a pressurized chamber, has been studied as an adjunct therapy, its availability is limited and its definitive benefit is still controversial.
Our sources also mention actinomycosis, which sound like a very specific type of bacterial infection, quite distinct from the others we've discussed.
It is indeed. Actinomycosis is caused by gram-positive rods, most commonly Actinomyces israeli, which normally inhabit our mouth, throat, and gastrointestinal tract. The cervicofacial form, affecting the head and neck, is the most common presentation, accounting for over half of cases. It typically presents with chronic soft tissue swelling, significant fibrosis or hardening of the tissue, and a telltale sinus discharge containing sulfur granules. Yes, these are yellowish microcolonies of the bacteria that can be seen on histological examination. The diagnosis is strongly supported by finding these gram-positive filamentous organisms and sulfur granules. Treatment typically involves long courses of high-dose intravenous, followed by oral penicillin therapy. Surgery is generally reserved for cases with extensive necrotic tissue, a poor response to antibiotics, or when a tissue biopsy is needed to definitively rule out malignancy, as it can mimic other more serious conditions.
Shifting gears now to viral infections, HPV or human papillomavirus, is widely known. But how does it manifest on the skin, and what are its surgical implications, particularly regarding malignancy?
Right, HPV encompasses over 100 types of small DNA viruses that are highly specific to humans. They are transmitted via direct skin-to-skin contact and are responsible for the development of verrucae, which we commonly call warts. While many common warts, particularly those on the hands and feet caused by specific HPV types, often regress spontaneously in individuals with healthy immune systems, certain types, especially in immunocompromised patients, carry a high risk of malignant transformation.
Okay, so some warts are riskier than others?
Definitely. A key detail here is epidermodysplasia verruciformis, a rare genetic skin disorder that confers an exceptionally high susceptibility to certain HPV types and a significant risk up to 50% of developing squamous cell carcinoma, particularly with HPV types 5 and 8. For mucosal types, like those causing condylomata acuminata, also known as genital or venereal warts, high-risk types such as 16, 18, 31, and 33 are strongly associated with malignant transformation, particularly cervical cancer. It's worth noting the significant impact of the quadrivalent HPV vaccine, which targets types 6, 11, 16, and 18, and has been associated with up to a 90% reduction in infections from those types, highlighting the power of preventative medicine.
So how are warts treated, especially the risky ones?
Treatment for symptomatic or high-risk lesions primarily focuses on physically destroying the affected cells through various methods. This includes cryotherapy, freezing, topical medications, electrodesiccation, burning, or laser therapy.
HIV profoundly impacts the immune system, and our sources show a wide range of skin manifestations that can occur, both directly and due to opportunistic infections.
You're absolutely right. HIV-infected patients are significantly more susceptible to both infectious and inflammatory skin conditions compared to the general population. These skin disorders can be a direct result of the HIV infection itself, or stem from opportunistic infections that arise due to the patient's weakened immune system. In early stages of HIV, nonspecific cutaneous manifestations can occur, such as an acute viral rash that looks similar to measles, affecting the face, trunk, and upper extremities. Common skin disorders can also present with atypical or more severe features, including recurrent shingles, varicella zoster, and hyperkeratotic warts that are unusually thick.
And in later stages?
In later stages of HIV, chronic infections like herpes simplex virus, HSV, and cytomegalovirus are common. Crucially, while Kaposi sarcoma, a type of vascular cancer, was once highly prevalent in AIDS patients and a defining feature.
Right, I remember that connection being highlighted.
Its rates have sharply declined since the widespread use of highly active antiretroviral therapy, or HAART. That's been a huge success story. However, other cutaneous malignancies, such as basal cell carcinoma, still remain a significant risk for HIV patients. From a surgical perspective, it's important to note that comorbidities in HIV patients, such as malnutrition and decreased immune cell counts, can lead to delayed and attenuated wound healing capacity, which impacts surgical outcomes and requires careful management.
We've covered inflammatory conditions and injuries, but the skin, like any organ, can also develop tumors, both benign and malignant. Let's start with benign growths, which are mostly harmless but sometimes troublesome. Our sources describe hemangiomas as quite common in children.
Yes, hemangiomas are benign vascular tumors, essentially collections of extra blood vessels. They are fascinating because of their natural history. They typically appear shortly after birth, grow rapidly during the first year of life, and then gradually involute, meaning they shrink and often disappear entirely, in over 90% of cases during childhood.
So most just go away on their own.
The vast majority, yes. Because of this natural tendency to resolve, most hemangiomas are managed non-surgically, with just observation. Surgical resection is only indicated in specific circumstances, such as when the hemangioma obstructs vital functions like the airway or vision, or if it causes high-output heart failure due to shunting a large percentage of cardiac output. Propranolol, a common heart medication, has become the first-line therapy for these infantile hemangiomas, causing significant cessation of growth and, in most cases, actual regression of the lesions.
Nevi, or moles, or something most of us have. When do these common skin growths become a concern, particularly in terms of malignant potential.
Right. Nevi are essentially areas where melanocytes, the pigment-producing cells, have multiplied. While most nevi are benign and completely harmless and can even spontaneously regress, it's the congenital nevi, those present at birth, especially very large congenital nevi, defined as larger than 20 centimeters in diameter, that pose a significant concern.
The really big ones.
Exactly. These carry up to a 5% chance of developing into malignant melanoma, sometimes even in early childhood. Therefore, the treatment for these high-risk congenital nevifoli often consists of early surgical excision to reduce that oncologic risk. Larger lesions might require multiple staged excisions or tissue expansion techniques to remove completely.
Our sources also break down different types of skin cysts. What are the most common ones you encounter, and how are they typically treated?
Cutaneous cysts are benign lesions characterized by an overgrowth of epidermis towards the center, resulting in the accumulation of keratin, which is the same protein that makes up your hair and nails. The most common type is the epidermoid cyst, often mistakenly referred to as a sebaceous cyst. These typically result from a blocked hair follicle and appear as a lump under the skin with often a small central blackhead. Another common type is the tricholemmal cyst, which is derived from the outer sheath of hair follicles and is almost always found on the scalp, more commonly in women. A third type is a dermoid cyst, which is congenital, meaning present from birth, and results from embryonic cells becoming trapped. These are often found on the face and, in some rare cases, can even communicate with structures inside the skull.
Hand treatment.
The treatment for all these cystic structures is typically surgical excision, with careful attention paid to removing the entire cyst lining to prevent recurrence. If you leave even a piece of the lining, it can grow back.
Keratosis sounds like a general term for a skin condition. What are the key distinctions here, and what should we be aware of regarding their potential to turn cancerous?
That's a good point. When we talk about keratosis in this context, two main types are highlighted, and they have very different implications. First, actinic keratoses are considered abnormal growths of epidermal keratinocytes. They represent a spectrum of disease, from simple sun damage to actual early squamous cell carcinoma.
So they're precancerous.
Essentially, yes. They are very common in fair-skinned, elderly individuals and appear in sun-exposed areas. UV radiation exposure is the greatest risk factor. These lesions can be reddish and scaly or thick and crusty. Crucially, about 10% of actinic keratoses can transform into invasive squamous cell carcinoma, with progression taking about 2 years on average. So they are important warning signs. The presence of actinic keratosis also serves as a predictor for the future development of other squamous cell and basal cell carcinomas.
Okay, so those need watching. What about the other type?
In contrast, seborrheic keratoses are completely benign lesions of the epidermis that typically appear as well demarcated, stuck on papules or plaques, often in elderly individuals. They might be brown, black, or tan and can feel greasy. They carry absolutely no malignant potential, and treatment is primarily for cosmetic purposes or if they become irritated or itchy. So while both are called keratoses, their clinical significance is vastly different.
And what about other common soft tissue lumps and bumps like skin tags or lipomas? How do we differentiate the benign from something that might be more serious?
Acrocordons, commonly known as skin tags, are benign, small, fleshy lesions often found in areas of friction like the neck, armpits, or groin. While they can sometimes become irritated, their removal is generally for cosmetic reasons. Dermatofibromas are benign cutaneous growths, often appearing on the lower extremities, that characteristically dimple inward when pinched. These are typically asymptomatic and don't require treatment. Lipomas are the most common type of benign fatty tumor under the skin. They are typically painless, slow-growing, soft, and mobile masses of subcutaneous fatty tissue.
Very common.
Extremely common. While usually small, they can sometimes reach quite large sizes. Surgical removal is indicated if they cause local pain, are growing rapidly, or are in cosmetically sensitive areas. Here's a crucial distinction for surgeons, though. It's vital to differentiate a lipoma from a malignant liposarcoma.
Ah, the cancerous version.
Yes. A liposarcoma is a type of cancer that arises from fat cells and is often deep-seated, painful, and rapidly growing, and it is invasive. Therefore, imaging like an MRI or CT scan is often recommended prior to any surgical removal of a suspicious fatty tumor to ensure it's not a more aggressive liposarcoma.
Even nerve tissue can form benign tumors. What are we looking at here, and when do these neural growths become symptomatic?
That's correct. Even nerve tissue can give rise to benign growths. Neuromas, for instance, are not true tumors in the sense of a clonal proliferation, but rather a disordered, tangled growth of Schwann cells and nerve axons. They often occur at sites of previous trauma or within surgical scar lines, and are typically quite painful due to their disorganized nature. Schwannomas are benign proliferations of Schwann cells, which are the cells that form the myelin sheath around peripheral nerves. These tumors contain no nerve fibers themselves, but they can cause pain or numbness by displacing or compressing the affected nerve, leading to symptoms along the nerve's distribution, like a tingling sensation down your arm. Neurofibromas, in contrast, are benign proliferations that involve all nerve elements: Schwann cells, fibroblasts, and nerve fibers. They typically present as fleshy, non-tender, soft masses on the skin. While often asymptomatic, the development of new pain or rapid growth at the site of a previously asymptomatic neurofibroma is a critical warning sign and may indicate a rare malignant transformation.
So new pain is a red flag.
Definitely. This would then necessitate surgical excision and biopsy to confirm the diagnosis.
Now we turn to the serious side of skin health. Malignant tumors. Basal cell carcinoma is described as the most common cancer in the U.S., a staggering 1 million new cases each year. What makes it so prevalent, and what should we know about its behavior?
Basal cell carcinoma, or BCC, is indeed incredibly prevalent, accounting for about 75% of all non-melanoma skin cancers and roughly 1 in 4 of all cancers diagnosed each year in the United States. It's huge. Its high prevalence is strongly linked to sun exposure, particularly intense intermittent UVB exposure during adolescence, though it often appears much later, with a latency period that can range from 20 to 50 years.
Decades later.
Exactly. It commonly occurs on sun-exposed areas of the skin, such as the face, especially the nose, eyelids, and ears. Because melanin provides natural photoprotection, dark-skinned individuals are far less commonly affected. While BCC primarily involves local invasion and rarely spreads to distant parts of the body, if left untreated, it can still cause significant morbidity due to its destructive growth pattern, leading to disfigurement and damage to underlying structures.
So it doesn't spread much, but it destroys locally.
That's the main characteristic, yes. There are multiple variants of BCC, and their presentation can vary widely. The most common subtype is the nodular variant, which classically appears as a raised, pearly pink bump with tiny visible blood vessels on its surface, and sometimes a depressed center with raised rolled borders, giving it the classic rodent ulcer appearance. Superficial spreading BCC is confined to the epidermis, appearing as a flat, pink, scaling, or crusting patch, often mistaken for eczema or a fungal infection. More aggressive subtypes include the infiltrative form, which blends with surrounding skin and has indistinct margins, and the morphiform subtype, representing only a small percentage of BCCs, but being the most aggressive, often presenting as an enlarging, scar-like hardened area, making clinical margin assessment difficult and leading to higher rates of positive margins after excision. There's also a pigmented variant that can be difficult to distinguish from certain melanoma subtypes.
How is BCC treated then?
Treatment of BCC depends on its size, location, type, and risk profile. Surgical excision is a primary treatment, with recommended margins varying based on the tumor's characteristics and location. For complex cases, such as those with aggressive features, poorly defined margins, recurrent tumors, or those located in cosmetically sensitive areas, particularly the midface, Mohs micrographic surgery is often considered the treatment of choice.
Mohs surgery?
Yes, this specialized technique involves removing the tumor layer by layer and immediately examining each layer under a microscope to ensure all cancer cells are removed while sparing as much healthy tissue as possible. It leads to very high cure rates. Other options include destructive techniques like cautery and cryosurgery, and radiation therapy for patients who are not good surgical candidates. Patients with BCC require regular follow-up with full skin examinations, as there's a significant risk of developing new primary BCCs after initial treatment.
Squamous cell carcinoma, or SCC, is the second most common skin cancer, and our sources highlight its strong link to UV radiation, similar to BCC, but also other important risk factors.
Absolutely. SCC also largely stems from UV exposure, but it has several other crucial risk factors, including immunosuppression from conditions like organ transplants or HIV, chronic wounds, and even old burn scars. Clinically, it often presents as a scaly or ulcerated bump or patch. Bleeding of the lesion with minimal trauma is not uncommon, but interestingly, pain is rare, which can sometimes, unfortunately, delay diagnosis.
Painless bleeding
can be a sign, yes. It's important to differentiate between in situ forms, where the cancer is confined to the very top layer of the skin, and invasive SCC. Actinic keratosis, which we discussed earlier, is a very common in situ precursor. Another in situ variant is bone disease, characterized by full-thickness abnormal growth throughout the epidermis, which appears as a scaly red patch and has about a 10% chance of becoming invasive. Invasive SCC can arise spontaneously or more commonly from these precursors. What's crucial to understand is that de novo invasive SCC, especially in immunocompromised patients, has a higher metastatic rate, meaning it's more likely to spread.
Ah, so SCC can spread more readily than BCC.
Generally, yes, especially certain subtypes or in certain patient populations. Invasive SCC arising in areas of chronic wounds or burn scars, known as Marjolins ulcers, also have a higher potential to spread.
And the treatment approach.
Prognosis and treatment depend on several factors, including the tumor size, depth, location, and presence of any high-risk features like rapid growth or nerve involvement. When feasible, wide surgical excision, including the subcutaneous fat, is the treatment of choice, with appropriate margins depending on the risk of the lesion. Mohs micrographic surgery is also indicated for high-risk lesions due to its precise margin control and lower recurrence rates. Lymph node dissection is performed if the lymph nodes feel enlarged, and radiation therapy is typically reserved as primary therapy for patients who can't have surgery or as an additional therapy after surgical removal for large, high-risk tumors.
Melanoma is perhaps the most feared skin cancer due to its aggressive nature and metastatic potential, and our sources provide extensive detail on this. It seems to be a rapidly growing concern.
Indeed. The incidence of melanoma is unfortunately rising faster than most other solid malignancies. While it primarily arises from melanocytes in the skin, it can also originate from mucosal surfaces in various parts of the body, including the mouth, eyes, and even the anal or genital areas. Its characteristic tendency to metastasize, meaning to spread aggressively to distant parts of the body, confers a poor prognosis once it has spread, making early detection absolutely vital.
And the risk factors are mainly UV related.
The most important risk factor for melanoma development is exposure to UV radiation, particularly from tanning beds, with studies showing a twofold increased risk for adolescents and young adults with more than 10 tanning sessions. Severe childhood sunburns are also strongly associated.
Tanning beds are a big one then.
A very significant risk factor, yes. Other risk factors include a personal or family history of melanoma and the presence of dysplastic nivi, which are atypical moles. Clinically, melanoma often starts as a localized radial growth phase across the surface before progressing to a more aggressive vertical growth phase that invades deeper. Approximately 30% of melanomas arise from a pre-existing mole.
And the types.
There are several common clinical subtypes. Superficial spreading melanoma is the most common, accounting for 50% to 70% of cases, typically arising from a precursor mole. Nodular melanoma, comprising 15% to 30% of cases, often arises spontaneously, is generally more aggressive, and can be diagnosed at a later stage, sometimes lacking melanin, making them appear pink or flesh-colored, which can delay diagnosis. Lentigo maligna melanoma is a less aggressive in situ subtype, while acral lentiginous melanoma is found on palms, soles, and undernails, not thought to be due to sun exposure, and more common in darker-skinned individuals.
So how do we spot these, the ABCDEs?
Exactly. For identifying suspicious lesions, the ABCDE characteristics are crucial. Asymmetry, irregular borders, color variations, multiple shades or uneven color, a diameter greater than 6 mm, about the size of a pencil eraser, and most importantly, evolution or change in size, shape, or color over time. Any pigmented lesion that has enlarged, ulcerated, or bled is also a red flag and needs checking out.
Diagnosis and staging seem particularly detailed for melanoma. What does the workup involve, and what are the most critical prognostic indicators?
The workup for melanoma begins with a thorough history and physical exam, where the entire skin should be checked for any other suspicious lesions, and all regional lymph node basins should be examined for enlargement. An excisional biopsy, where the entire suspicious lesion is removed with a small margin, is generally preferred for diagnosis, as it allows the pathologist to evaluate the full thickness of the lesion.
And prognosis depends heavily on...
Prognostic indicators are critical for determining patient outlook and guiding treatment. The Breslow tumor thickness, which measures the depth of penetration of the lesion from the top of the epidermis into the dermal layer, is the single most important prognostic indicator.
Breslow thickness, got it.
It's directly related to the risk of disease progression. Other significant indicators of a worse prognosis include ulceration of the tumor surface, a high mitotic rate, how quickly cells are dividing, the number of affected lymph nodes, and elevated lactate dehydrogenase, LDH levels, especially in metastatic disease. For patients with more advanced disease, there is a higher risk for distant metastasis and baseline imaging, including CT scans or whole body PE scans may be recommended.
And the sentinel lymph node biopsy, that sounds important.
It is. The sentinel lymph node biopsy, or SLNB technique, has become a cornerstone in melanoma management. This is a standard staging procedure used to evaluate regional lymph nodes for patients who don't have clinically obvious lymph node involvement. It identifies the very first draining lymph node from the primary lesion, the sentinel node. This technique has shown excellent accuracy and significantly less morbidity compared to surgically removing all the lymph nodes in a basin.
Less invasive.
Much less invasive. It helps doctors understand if the cancer has started to spread and guides further treatment. The procedure involves injecting a small amount of radioactive tracer and blue dye around the melanoma, which then travels to the sentinel node. The surgeon then locates and removes only this node to examine it for microscopic metastasis.
Given the aggressive nature of melanoma, what are the primary surgical management strategies for the tumor itself and any involved lymph nodes? And what happens if it has already spread regionally or distantly?
Surgical management of the primary melanoma involves wide local excision where the tumor is removed along with the surrounding margin of healthy tissue. The size of this margin depends on the tumor thickness. For example, a very thin melanoma might need a 0.5 to 1 centimeter margin, while a thicker one might require a 2 centimeter margin.
Okay.
If the sentinel lymph node biopsy is positive, meaning cancer cells are found, a completion lymphadenectomy, removing all the remaining lymph nodes in that basin, is commonly performed. However, current research is refining its role, as it doesn't always improve overall survival, and most of these nodal basins do not contain additional disease. So it's becoming a bit more nuanced.
Right.
For patients with clinically enlarged lymph nodes but no signs of distant metastasis, a full therapeutic lymph node dissection is performed and can be associated with reasonable 5-year survival rates. Special considerations exist for specific anatomical locations. For example, melanomas on the face, anterior scalp, and ear with a positive sentinel lymph node may require additional surgery around the salivary gland in addition to neck dissection.
And if it's spread beyond the initial site?
For regional and distant metastasis, if the cancer has spread to nearby skin or lymphatics, but not yet to distant organs, these areas are surgically removed when feasible. For regional disease that can't be completely excised, specialized techniques like isolated limb perfusion or isolated limb infusion can be used. These techniques involve temporarily isolating a limb's blood supply to administer high doses of chemotherapy directly to the affected limb, minimizing systemic drug toxicity, and they have shown encouraging response rates.
Wow, isolating the limb for chemo.
It's quite a procedure, yes. The most common sites of distant metastasis for melanoma are the lung and liver, followed by the brain, gastrointestinal tract, and distant skin. A limited subset of patients with small, confined distant metastases, especially to the brain, GI tract, or distant skin, can benefit from surgical resection or targeted radiation therapy. Surgery may also provide palliation for symptoms like intestinal obstruction or bleeding.
Beyond surgery, what are the adjuvant and palliative therapies for melanoma, especially with the remarkable recent advancements in drug therapy for metastatic disease?
Historically, adjuvant therapy, meaning therapy given after the primary treatment to prevent recurrence with high-dose interferon, was used. It showed some disease-free survival advantages for patients with thicker melanomas or lymph node involvement. However, it's poorly tolerated due to significant side effects, and analyses haven't definitively shown a clear improvement in overall survival, so its use has declined.
And the new drugs?
The landscape of drug therapy for metastatic melanoma has seen truly remarkable and exciting advancements recently. While medical options were historically very limited, several new drug classes have shown significant promise and survival benefits in randomized studies. These include targeted therapies like BRAF inhibitors for patients with specific genetic mutations in their melanoma, and immunotherapies such as anti-PD-1 antibodies and CTLA-4 antibodies, which harness the body's own immune system to fight the cancer.
Immunotherapy, right.
Exactly. These new agents have truly transformed the treatment of metastatic melanoma, offering hope where there was once little. As patients can develop resistance to these drugs over time, surgery will likely continue to play an increasingly adjunctive role, complementing the systemic therapies by addressing localized disease or complications.
Any special circumstances?
Yes. A few are worth noting. Melanoma in pregnant women generally has a similar prognosis to non-pregnant women, and sentinel lymph node biopsy can often be done safely during pregnancy. malignancy. Melanoma of unknown primary, where the original lesion cannot be found, occurs in a small percentage of cases and most commonly presents in the lymph nodes. Surprisingly, its prognosis is comparable to melanoma with a known primary of the same stage. Non-cutaneous melanomas, such as ocular melanoma, have a unique pattern of metastasis, primarily spreading to the liver rather than regional lymph nodes, and mucosal melanomas, found in areas like the oral cavity or anus, generally carry a worse prognosis than melanomas that originate in the skin.
While rarer than melanoma, Merkel cell carcinoma sounds like a particularly aggressive skin cancer with a poor prognosis. What defines it, and how is it managed?
Merkel cell carcinoma, or MCC, is indeed an aggressive neuroendocrine tumor of the skin, and its incidence has been rapidly increasing. Despite being rarer than melanoma, its prognosis is unfortunately much worse, with a 5-year survival rate of only about 46%.
Wow, much lower.
Significantly lower. It's most often diagnosed in elderly patients and is strongly linked to UV exposure and immunosuppression, such as in organ transplant recipients. MCC typically presents as a rapidly growing, often flesh-colored to red or purple lump or plaque. It has a high rate of regional nodal involvement, found in 30% of patients at diagnosis, and about 50% will develop systemic disease, spreading to sites like the skin, distant lymph nodes, liver, lung, bone, and brain. The diagnosis is often confirmed using specific protein markers seen on biopsy, like cytokeratin 20.
And the management?
Management typically involves sentinel lymph node biopsy for staging in patients without clinically obvious nodal disease, followed by wide surgical excision of the primary lesion with recommended margins of 1 to 3 centimeters. Chemotherapy and adjuvant radiation therapy are commonly used, especially for regional nodal disease, although definitive survival benefit data for specific regimens are still being studied. MCC has notoriously high recurrence rates, often within 2 to 5 years, and regional lymph node disease is particularly common, underscoring its aggressive nature.
Kaposi sarcoma is known for its strong association with compromised immune systems. What's its nature and how has its treatment evolved?
Kaposi sarcoma is a type of vascular growth disorder driven by human herpes virus 8, or HHV8. It primarily affects individuals with compromised immune systems, most notably those with HIV and transplant recipients on immunosuppressive medications. It classically presents as multifocal, rubbery, blue-red nodules, primarily on the skin, but can occur anywhere in the body, including internal organs. The good news is that with the widespread use of highly active antiretroviral therapy, or HAART, for AIDS-associated Kaposi sarcoma, patients often experience dramatic treatment responses and a sharp decline in incidence.
So HAART really changed things.
It really did. While surgical biopsy is important for diagnosis, surgery is generally limited to palliative measures, meaning managing symptoms like bleeding or discomfort, given its systemic nature and high local recurrence rates. It's often more about controlling the disease than achieving a complete cure through surgery alone.
Our sources also mention dermatofibrosarcoma protuberans, or DFSP, which sounds like another distinct type of sarcoma to be aware of.
DFSP is a rare, low-grade sarcoma that originates from fibroblasts, the cells that produce connective tissue. While it has a very low potential to spread to distant parts of the body, it behaves aggressively locally, characterized by what are described as finger-like extensions that creep into surrounding tissue.
Finger-like extensions. Sounds invasive.
It is locally. This makes wide local excision or Mohs micrographic surgery crucial to ensure all these extensions are removed, even though it still carries a relatively high local recurrence rate, often between 50% to 75% of cases, usually within 3 years of treatment. Its diagnosis is often confirmed by specific markers on biopsy. Because of its local invasiveness, meticulous surgical technique is paramount to get clear margins.
And another type of soft tissue sarcoma, malignant fibrous histiocytoma, also called undifferentiated pleomorphic sarcoma and myxofibrosarcoma.
Right. This is an uncommon cutaneous spindle cell sarcoma typically found in elderly patients, often presenting as a solitary, soft to firm lump under the skin. Complete surgical resection is the primary treatment of choice. Adjuvant radiation therapy is often used to help with local control, especially for patients where it was difficult to get clear surgical margins, though recurrence can still be significant even after seemingly complete removal. It's important to note that if distant metastasis is present, surgical resection is generally not the primary treatment, as it suggests systemic disease that requires broader therapy.
Angiosarcoma sounds particularly grim with its poor prognosis. What makes it so aggressive?
Angiosarcoma is an uncommon but extremely aggressive cancer that arises from vascular endothelial cells, the cells that line blood and lymphatic vessels. It carries a very poor prognosis, with an estimated 5-year survival rate of only about 15%.
Only 15%.
Yes, very poor. It has several variants, including one that often presents on the head and neck, appearing as an ill-defined red patch with satellite lesions, lymphedema-associated angiosarcoma, which develops on an extremity after chronic swelling from lymph node removal, and radiation-induced angiosarcoma, which occurs years after radiation therapy to an area. Surgical resection is the treatment of choice for localized disease, but recurrence rates are notably high. Systemic therapies typically offer only palliation, reflecting the aggressive nature of this cancer.
Finally, extramammary Paget's disease. What's unique about this adenocarcinoma, especially for surgeons?
Extramammary Paget's disease is a rare adenocarcinoma, a type of gland cancer that arises from apocrine glands in the skin. It presents as eczema-like, red, scaly plaques in specific regions such as the armpits, perianal, and genital areas. A critical characteristic for surgeons, and one that requires acute awareness, is its high incidence of concomitant other malignancies.
Other cancers at the same time.
Exactly. About 40% of cases are associated with underlying primary gastrointestinal and genitourinary cancers. This means that after a diagnosis of extramammary Paget's disease is made, a diligent search for these internal malignancies through imaging and other diagnostic tests is absolutely required. Treatment involves surgical resection with negative microscopic margins, meaning no cancer cells at the edges of the removed tissue, and adjuvant radiation may be considered for additional local control.
Wow, what an incredible journey we've taken. From the microscopic, constantly regenerating layers of the epidermis to the intricate landscape of malignant skin tumors. We've seen how this largest organ, our skin, is truly a marvel of protection, sensation, and regeneration, constantly adapting to our environment and defending us. Our deep dive today aimed to give you a shortcut to being truly well-informed about the skin and subcutaneous tissue, distilling complex medical information into clear, actionable insights, and highlighting why so many medical and surgical specialties are dedicated to its health.
Indeed. Understanding the skin's intricate architecture from its basic cellular components like keratinocytes and those vital immune sentinels, to the advanced surgical techniques and targeted drug therapies used to treat its diverse pathologies. It truly underscores why its health is paramount to our overall well-being and satisfaction. It's a field where continuous innovation is happening at an incredible pace, driven by the sheer complexity and vital importance of this remarkable organ.
Given the skin's constant interaction with the environment, its continuous regeneration, and its crucial role in immunity and protection, how might future advancements in bioengineered skin or targeted gene therapies allow us to not just treat disease, but fundamentally enhance our body's outermost fortress against the world?